So today we will be discussing about the role of Pioglitazone and Dapaglifozin in the Indian diabetics. This is an industry-sponsored symposium contributed by Eris. Now this molecule combination, this fixed drug combination was first in fact tested by Akums, and Akums was the first to launch in February 2025. Probably they are outsourcing from Akums. So we thank Eris for the contribution to this conference for the 2 days event. Essentially, we all know about the type 2 diabetes. History of type 2 diabetes starts from the insulin resistance and the decline of the beta cell function as the age of the type 2 diabetes advances. Addressing insulin resistance and protecting the beta cell in the newly diagnosed type 2 diabetes mellitus patients, which drug should we prefer? As far as Indian context is concerned, as far as Indian diabetics are concerned, we all know that how different are these Indian diabetics. Basically, you have that Asian Indian phenotype, which clearly has got the as such thin but then more fat and all these issues that we have, the more insulin resistance. Once you go home from 2 days conference, for the next 15 days, do an exercise. Many patients come to us for checkups, that we want to do some checkups. Do two things. Just get the routine patients who are asking for checkups, ask them to go for fasting blood sugar, post-glucose blood sugar, fasting insulin level and HOMA-IR2. Do some study of 10 patients, you realize how much insulin resistance do you have in our population. You will have patients who have got a normal fasting sugar, normal post-glucose blood sugar, but insulin level of 19-20. Indian cities said to levels, Indian cities said to be around 6 to 8. You will have patients who have got a normal FBS, normal PG2 but insulin levels of 19-20. These patients are the patients who are likely to go into the phase of pre-diabetes. So you will be able to detect them prior to your pre-diabetes. That's why the concept of that PG 1 hour that we discussed today morning, which was discussed in the IVF meeting, came. So we have more insulin resistance, a basic fundamental issue. We have a rapid decline in beta cell function, resulting in low insulin reserve compared to the Western population. And our beta cell dysfunction occurs quite early and rapidly in the Asian Indians. So essentially, when we talk of Indian diabetics, there are two areas we are interested in. One is the insulin resistance and obviously the fatty liver part, which is part of the entire syndrome. So if you have a molecule which helps you in tackling insulin resistance and tackling the fatty liver part as a part of the mechanism of action, it is going to be a great help in treating the patients. Glycemic benefits and improved insulin sensitivity, most of the studies of these are known, very old, and we all know about it. We have been seeing him in these conferences since last so many years. We all know that the Pioglitazone and metformin monotherapies are equally effective in lowering the A1C and FVG. But improvements in insulin sensitivity, as demonstrated by increases in HOMA-S and reductions in FSI, are more pronounced in patients with Pioglitazone therapy. So when you initiate DEPA and Pio early, you have a long-term beta cell preservation. It's very important. When you diagnose a patient, you put the patient on OHN, over a period of years, you have seen that the sugar control would gradually decline. Because the beta cells, they fail. So advantage of this, when you combine SGLT2 inhibitors with Pioglitazone, is you have some beta cell rest. And because of this insulin sparing effect of Pio and DEPA, Pio is insulin sensitive that we all know. And DEPA is our glucose, this is a glucosuric agent. So it's very useful combination for insulin patients, because we all know that insulin resistance is central in all the cardiovascular and metabolic pathologies. Whether we talk of in all these pathologies, which ultimately your oxidative stress or hormonal imbalance or inflammation or glucotoxicity or insulin resistance, genetic susceptibility of Indians, all these things ultimately leads to insulin resistance. And this IR is the thing responsible for the stroke, for the myocardial infarctions, your CKDs, your diabetes, your fatty livers. 40% of the normal population of India has got fatty liver. LDL, HDL, fractional imbalance, your chronic inflammatory states, altered lipid metabolism. So basically you have got high prevalence of IR in the Indian population. So these molecules are targeting that particular address. We have 6 different classes, but they have different mechanisms of action. Insulin resistance is a very important pathophysiological defect in type 2 diabetes mellitus. In treating IR, if it is my requirement, which drug is good? Wikipedia's trial very clearly showed that in 10 years, 20 years, you target solely glucose lowering, it benefits the cardiorenal complications over several years. So it's very important for us that if you are able to decrease the HbA1c in the initial when you diagnose, whether you give intensive insulin therapy, whether you give aggressive therapy with your SGLT2 inhibitors, metformin, in the initial first 3 months, if you are able to lower your HbA1c, if you are able to lower the sugars fast, the metabolic legacy effect, the metabolic memory effect is going to be helpful for preserving the beta cell function for a longer period in a given diabetic patients. So the early initiation of these molecules is very useful for sustainable glycemic control. We all have seen in our clinical practice, when you put the patient on Pio, and for some reason if you withdraw, sugar would go out of control. You need to add, you have a little more issue, you have a little difficult time in controlling those sugars. When because of edema or when for other reason you have to taper down the Pioglitazone or you have to stop down the Pioglitazone. Because sustainability of glycemic control is a challenge, and this challenge is a molecule, Dapa and Pio, both are going to help you in your clinical armamentarium of the medications that you have. The Arab study very clearly showed as the age of the diabetes advances, the control is you are going to lose the control very clearly. When you are going to lose the control, if you have these molecules, when you diagnose, put the patient first on these two molecules, you are going to obviously reap the benefits over a period of next 10 years. Studies have very clearly shown that the Pioglitazone has had significantly improved glycemic control even 4.1 years after starting the treatment compared to the other molecules that we use generally. 10-year follow-up of intensive glucose control in type 2 diabetes mellitus. Targeting glucose lowering provides benefits in cardiorenal complications over several years, but it failed to decrease the cardiovascular events because you need to maintain the sugar level in a very nice sustainable manner. So only intensive glucose would not be enough. You need to understand that the early use would provide the legacy effect with whatever ways you want to achieve, but the attenuation of the metabolic memory would have a better cardiorenal protection. So in this particular group of medications that we have, and the Indian scenario where we have more insulin resistance, we have more fatty liver, this combination of the Pioglitazone and Dapaglifozin would fit perfectly well, because it would address the cardiorenal hepatic metabolic benefits of Dapa are also very well proven. So you have established benefits in non-diabetic patients as well as diabetic patients that we already know. You have established renal benefits in DAPA CKD trial. You have reduction of hepatic steatosis in MFLD patients, and you have weight loss benefits. We all know that the shift of this diabetes management have moved from a glucose-centric to the cardiorenal-centric management. And though that is why you use the term disease-modifying diabetes medications. Because these medications would not only improve HbA1c, not only it will improve the patient's CV, but and the renal outcomes. And long term, it would have a very beneficial effect for the diabetic patient's overall mortality and the morbidity. Professor D. Francois had advocated that the disease-modifying anti-diabetic drugs like your SGLT2 inhibitors, your GLP-1 RAs, Pioglitazone and metformin, all these molecules whenever possible you should use as a first instance, because these drugs would be effective in the cardiorenal metabolic drugs in combination. It would be beneficial in the diabetic patients to decrease the target organ involvement on a long-term basis. We all know that he also had put its perspective on the, because you know the Dapaglifozin would reduce the, Dapaglifozin would reduce the body weight, it reduce the fluid retention, it would reduce the body weight. Pio would increase fluid retention, body weight. So it will have a neutral effect. That's an advantage in our Indian group of patients. Your blood pressure would decrease both, and hypoglycemia is not there in both of these cases. Additional, there is 2 to 3 millimeter benefit of systolic blood pressure, diastolic blood pressure drop in when you use these two molecules combined, and there is no hypoglycemic effect with this combination. So this is in a way a win-win situation for the Indian patient specifically. You in Pioglitazone, you have fluid retention, weight gain. At the very same time, your diuretic effect of DAPA counterbalance where DAPA's your weight loss effect. And that is why it's a very strategic combination that balance the benefits and risk of therapy in type 2 diabetes mellitus. Your DAPA would reduce HbA1c to 1.5%, Pio would be around 1.2%. So you have a net enhanced HbA1c reduction. Beta cell function preservation would be more with Pio, so there is sustained preservation of the beta cells. Insulin sensitivity would increase in DAPA and Pio, both Pio more. So when you combine both, you have much better insulin sensitivity in these group of patients. So you have a complementary mechanism. Pio would have insulin sensitizing action, DAPA would have insulin independent action, and then additive glycemic control. Apart from the beta cell sparing, there won't be any hypoglycemia and there is no dose adjustment are required. We all know that ADA has repeatedly emphasized that you need to screen for fatty liver. FIB4 screening is very important and must do in OPD. And with all the patients, diabetics must undergo along with CBC, SGPT-OT, so that you can have the FIB4 scoring, specifically who are obese. And these patients, if the FIB4 is high, then obviously you need to choose the medication which should reduce the fat in the liver on a long-term basis, whether you use SGLT inhibitor, whether you use GLP-1RA, whether you use Pioglitazone. Any of the molecules you use, but you need to reduce the dose, that you reduce the fat in the liver, which is already there in diabetics. This is the only available combination, DAPA and Pioglitazone, which would be helpful in treating our Indian patients. Obviously, it would fit in the diabetic treatment algorithm, which we all use in our day-to-day practice. Pioglitazone and saroglitazar, both are the molecules which are very good in reducing the fat content of the liver. My own personal experience has shown that liver enzymes, when they are more, saroglitazar would reduce to a better extent compared to Pioglitazone. But then these two molecules are more or less nice. So any of the molecules that you choose, depending on your patient profile. So there are many trials that we have for this DAPA and PA combination. The real world studies are there. There was one study where there were 888 type 2 diabetes patients, and using the SGLT2 inhibitors and Pio with a median dose of 15 milligram was associated with a higher likelihood of both the low fast square, the reassessment. So essentially what it might tries to convey is that you have significant reduction in the MASH, in the fatty liver, progression and the steatosis part. Because what happens is that in type 2 diabetic subjects, there is altered fat topography. So what happens is that you have more muscle fat, you have more plasma free fatty acid, you have more hepatic fat, you have more arterial fat, you have more subcu fat and more intra-abdominal fat. And now what Pio does is, there is redistribution of the visceral fat to subcutaneous regions. There is weight loss or maintenance of weight with DAPA and Pio. So it's a win-win situation for the patient very clearly. And DAPA, would reduce because of diuretic effect, reduce the preload and afterload. It would reduce the oxidative stress, reduce the hypertrophy, inflammation, and increase the hematocrit level. Sometimes you need to take care. Sometimes hematocrit level is an issue when you treat patients with DAPA, and sometimes you need to be careful. Pioglitazone reduces the hypertrophy, reduces the inflammation, reduces the cell proliferation, reduces the fibrosis. So it's very important that whether you talk of DAPA for heart failure, reduction, CV death, everywhere DAPA trials are very clearly shown. For Pioglitazone, Periscope, PR-active, all the trials have shown that you have reduction in the progression of the atherosclerosis and progression of the carotid intima media thickness also. All the results, all the major trials are there. For the lack of time, I would switch on. The trials are shown that the MACE risk was decreased by 24%, MI risk by 19%, and the stroke risk by 28%, CV death by 11%, heart failure by 33%. So essentially, this combination is a very useful combination for beta cell preservation, for the patients who are having fatty livers, for patients who are having ASCVD, and patient has got a very good renal effects also. So essentially, this is molecule which is probably, these molecules are probably must in patients who are having diabetes. And all of the following need to be addressed in the Indian diabetes patient, which we just discussed: insulin resistance, cardiorenal metabolic abnormalities, Legas effect and durability, high prevalence of MASH, MFLD, preserves the pancreatic beta cells, and there is hypoglycemia risk. And lastly, the triad of heart, brain and liver, a common concern in type 2 diabetes mellitus. It can be addressed with these disease modifying drugs, a term which we used to generally use for the rheumatology. Risk of stroke or transient TIAs, cardiovascular disease, MACE reduction, and development and progression of MFLD. So this molecule is combination would be a molecule which would be an important armamentarium in the treating diabetic patients in our country. Thank you.